This session has deliberately been named as Future. The future is right here. Believe me, this drug by the name of faricimab is very, very promising. Very promising. All of us are living in this very exciting times of this anti-VEGF. And believe me, right in front of our eyes, we have, seen starting from Macugen to Avastin to, ranibizumab to aflibercept, then Pagenex, now faricimab, and even 8 milligram aflibercept is on the way. So, as far as studies are concerned, this drug, faricimab, is very, very exciting, primarily because of, I think, durability. Hi, welcome.
Chandramohan, you also please come on to the dais. Chandramohan.
So, we will begin this session. I have with me a lot of renowned people here who do not require introduction. Dr. Ajit Babu and Dr. Mallika and Chandramohan and then Dr. Bhavik, James, everybody is here. And let's all celebrate this occasion by this laser show. If Roche people are ready, we'll start with this. Tejaswini, are you there? Yes. So we'll start and all of you should enjoy this laser show, which I think the audiovisual will convey the purpose of this session. Yes, you can start.
Once there was a woman named Gayatri. Her world was filled with colors and laughter, but fate had a different plan for her. She was diagnosed with AMD, and slowly her vision began to fade, affecting her quality of life and independence. As Gayatri's vision deteriorated, her world plunged into darkness. Simple tasks became challenges, and the fear of losing her independence overwhelmed her. Frequent visits to the ophthalmologist offered little hope, and the thought of repeated eye injections filled her with dread. In the midst of her struggles, Gayatri's ophthalmologist brought her newfound hope. He introduced her to Vabysmo, an innovative medicine that could change her life. With new hope to see better, she decided to take a leap of faith and embrace the light that Vabysmo offered. With each Vabysmo treatment, Gayatri felt the darkness lifting. Her vision began to clear and colors returned to her world. The fear and anxiety she once felt about her condition diminished, and she found a renewed sense of hope and optimism. With Vabysmo's transformative power, Gayatri's life bloomed anew. She no longer needed to rely on her loved ones for every little task. Her visits to the ophthalmologist were very satisfying, and her fear of injections was a thing of the past. Gayatri, with gratitude and joy.
I am forever grateful to my ophthalmologist and this revolutionary treatment, Vabysmo.
Through the light of innovation, Gayatri's story is a reminder that there is always hope in the face of adversity. For all patients with AMD and DME, with access to transformative treatments like Vabysmo, we can conquer even the darkest of challenges and embrace life's beauty once again.
Tejaswini, for this very nice laser show. I hope a lot of our patients, have the similar advantage with Gayatri had here, that they are able to water their plants accurately and put water into the pot rather than outside the pot. So with this we'll begin our session. You see, in this era of anti-VEGF, I normally try to classify anti-VEGF into first generation and second generation. First generation, all of us have experience with. That is with, starting with Avastin to ranibizumab to aflibercept. Also the brolucimab. But these newer generations of anti-VEGFs which have come up or are on the pipeline, a lot of them are in the pipeline also, which is one of them is faricimab, and 8 million aflibercept is also coming up. So the advantage is primarily of duration. Believe me, all these agents work. All of them, you start treatment, they work. But patients, you have to think about the patient, how many times he can come. Every 4 weeks, you keep calling, consultation, then imaging, then, a lot of things happen. But if we can have a drug where patient has to come less often means maybe Q10, Q12, I think the purpose is achieved. Patient's compliance will improve because patient will, then more often obey whatever you write. And if the compliance improves, then the effect on the disease also is better. Whereas if you see the real world scenarios, if you call patients every 4 weeks, compliance goes down to nearly 50%, and these patients don't come. And what happens if the patient does not come is the disease progresses, and then the results are not the same. And then the blame may go to the molecule, that this molecule does not work, that's up to your injection. So here is the role of this increased duration. And we have always been, taught or read about anti-VEGFs. But this molecule has double mechanism of action. It is not only anti-VEGF, but it, works against the Ang pathway also. So we'll request, Dr. Chandramohan to, Rajesh, to tell us something about this Ang2 and what is the role and how this drug can be exploited to its fullest.
Lower number of injections also translates to lower risk of endophthalmitis. Each injection is a risk.
Absolutely, because the more you keep poking the needle, it's a cumulative effect also. You see more the chance of infection. So I agree with you, Mali. Yes, Rajesh. Rajesh, try to be as brief as possible because we have to discuss this out rather than theoretical presentation.
Good morning, everybody. So I will be talking about the role of angiopoietin 2 in AMDs and DMEs. As it is a new molecule, I will be talking about its main pathophysiology. This is a disclaimer that Roche doesn't promote any off-label drugs, or please use with caution. So I'll be starting with what angiopoietin 1, normal levels of angiopoietin 1 does in the body. So angiopoietin 1 will bind with the tyrosine kinase receptors. So this binding promotes the vascular stability. Normally there will be a balance between the angiopoietin 1 and 2. So in healthy vessels, the angiopoietin 1 and tyrosine kinase signaling promotes the vascular stability. You can see the intact endothelial cells, pericytes. But when there are few conditions, retinal vascular diseases, AMDs, RVOs, diabetes, so there will be an imbalance between the angiopoietin 1 and 2, which we call it as a angiogenic switch. So this has been studied in various human vitreous samples, and the levels of angiotensin 1 when compared with the angiotensin 2, if you see the graph on the right side, you can see the angiopoietin 2 levels are significantly higher in various retinal diseases. When the angiopoietin levels are higher, they compete with the angiopoietin 1 for the tyrosine kinase, and they sensitize this tyrosine kinase that inhibits the vascular stability. Along with that, they will sensitize the blood vessels to the effects of VEGF. So VEGF-A also binds with the VEGF-R2 in higher levels of angiopoietin 2. This VEGF again promotes endothelial cell apoptosis and other factors which we know from many decades. So basically during this angiogenic switch, like I have said, angiopoietin 2 upregulation, VEGF upregulation, finally leading to vascular leakage, neovascularization and inflammation. This is how the angiopoietin binds. And there it sensitizes the blood vessels to inflammatory markers, cytokines, further elevates the VEGF-A levels and vascular leakage and neovascularization. There are various studies. These are all animal studies. So this is one Miles assay where blue dye, Evans blue dye has been injected into the mice intravenously, and after 2 days, they have intradermally injected cytokines, VEGF, and then they have checked the vascular leakage. In the angiopoietin deficient mice, the vascular leakage is significantly less. And this is another study where they have noted on the neovascularization. So they have taken breast tumor cells, they have cultured, and then they have cultured in an immunocompromised mice. So when they have the tumor mass has reached to a significant size of 150 cubic millimeters. So they have collected the tumor cells and then they have been exposed to anti-VEGF-A, angiopoietin, anti-angiopoietin, and then a dual mechanism. After a few days, they have studied and then they have noted the neovascularization has been significantly reduced in the dual mechanism and the pericyte coverage has been increased. This is another study where they have clinically induced choroidal neovascularization by producing laser spots, and the intensity of the choroidal neovascularization has been assessed at the 14th day by FFA. They have graded based on the hyperfluorescence, and then after injecting on the 15th day, and then they have again studied on these mice at the 28th day. So there has been a significantly reduced leakage in the combined and dual mechanism. There is another study which has shown the endothelial barrier function, TEER assay, trans-endothelial electrical resistance. So stem cells, human stem cells have been filtered and then they have been cultured, and they have been exposed to VEGF-A initially, and after 18th day, these cells have been exposed to different strengths of dual mechanism drugs, 0.5, 0.3 and 15 nm. So all these angiopoietin 2 combined mechanisms has shown a significant endothelial integrity. So like I said, the release of cytokine sensitizes the blood vessels, and apart from VEGF, they also lead to inflammatory mediators, macrophages, leukocytes. So this is another study which they have proven the cytokine production, which is higher in normal cells, has been reduced with dual mechanism. So they have done a cecal ligature puncture into the mice, and then they have taken the organs after sacrificing the mice, and they have studied the kidney and liver cytokines. Another study which showed their role on leukopoietic adhesion. So this is another one where they have injected single intraperitoneal injection lipopolysaccharide and then induced uveitis in these mice, and they have sacrificed, and then they have studied the retinal microscopy where they have seen leukocytic infiltration in a wild scenarios. So dual mechanism has been proved to synergically reduce the macrophagic infiltration. Always there should be a balance which needs to be maintained that has been disrupted in these diseased conditions. There are other exploratory research happening, whether they role in any fibrosis and integrins pathway. I'll skip this one because these are all on the exploratory conditions where they will be dealing with the pericytic apoptosis and astrocytic apoptosis. So angiotensin 1 activates the Tie2 receptors, and angiotensin 2 and VEGF are upregulated in the vitreous of people with disease conditions. So this angiotensin 2 inhibits the Tie2 receptors and promotes the inflammation. So a dual mechanism has been shown to increase the vascular stability. So faricimab is a bispecific antibody that independently binds and neutralizes these both molecules. This is a faricimab where two ends, one end binds the angiopoietin 2 and the other one binds with the VEGF. Together, a neutralization by faricimab may lead to more sustained stabilization of the vessels as opposed by the VEGF-A inhibition alone. Thank you for your patient listening. And Vabysmo stands for V VEGF-A for angiopoietin, BYS is a bispecific, and MO is a molecule. Thank you.
Thank you, Rajesh. It's a very quick and crisp presentation. If I see till now, anti-VEGF agents only were targeting the VEGF growth factor. Maybe 30 years ago when I was in Hopkins, we were simultaneously looking after a lot of molecules. And that MMPs is one of the agents we said can be very effective in regressing the new vessels. The other agent which I work personally is tyrosine kinase inhibitors. And if you see what ANG2 is a tyrosine kinase inhibitor, which work was getting done for past 30 years actually. So I'm very happy that people started thinking apart from VEGF, there is some other agents, so that a blanket means all agents need not be effective, like only VEGF will be effective in CNVMs. There is something else which also is required. And this very fact was proved by Narayan Netralaya. They have studied in DME patients actually. They taken the aqueous and then they measured all the levels of VEGF and angiopoietin also. And they found that some patients who are resistant to anti-VEGF injections, their levels of interleukins were raised. Means there is an inflammatory component. It is not only angiogenesis that need to be addressed, but the inflammatory component also need to be addressed. And I'm very excited, though I'm very new to this molecule, I'm very excited because it's a blanket. Again, it's addressing the anti-inflammatory and angiogenesis. And I feel that whatever my experience in the lab or in the clinic, I feel that it may address a lot of clinical cases which were resistant to some of the very effective anti-VEGF agents.
Just want to make
Thank
a
you,
point.
Rajesh.
Rajesh, what are the normal levels of Ang1 or Ang2 in the blood of a human being?
I actually don't know, sir, but I have asked them which structure of the eye is actually producing this. So the angiopoietin 2 is produced by the pericytes, and angiopoietin 1 is produced mainly by the endothelial cells. The actual levels I am not sure.
So, okay, in any case, you see there is a lot of excitement considering the dual mechanism. As Dr. Ajit Babu was saying that we have had, anti-VEGFs available. Like I say, even aflibercept has that advantage of increased duration. And aflibercept 8 milligram also is on the line. But this molecule, because of the, what you said, double mechanism of action, although we in India, I don't think so anybody has given any injection, but there is a lot of excitement, and we know that in US and other countries, a lot of people have shifted to. Any idea how much
Sir, one of my slides, I'll show you how much the angiotensin 2 is innovated in all the diseases like DME, AMD, and things. One slide is there.
So okay. After having understood the role of Ang1, Ang2 in this diseases, now we'll have some clinical diseases like nAMD and DME, where yes.
Yeah, just one comment before we move ahead. So why this molecule is promising is because it is targeting the basic pathology. What we see here is the endothelial tight junctions which become weak, right, in patients with diabetic retinopathy in general because of diabetes mellitus. And we know that angiotensin 2, as was described, supports that. So So we have a molecule here which is not just blocking the VEGF, but also going and attacking, or rather the targeting the basic pathology here.
That is the real excitement.
True.
That is the
Yes.
real excitement.
Correct.
That here is a molecule that targets two pathways.
True.
So there is the reason it's bispecific, and there are
No. The basic pathology in all this, they have all proved that the leakage is decreasing with even anti-VEGF agents also. In the basic experiments, this is common pathway we do actually. We have worked with all the lasers also, the amount of leakage, and we have seen some models of mice where the neovascularization also has happened, and we have reduced it. In diabetic mice, actually that is sugar diabetic rats are there. We have studied that also, and the amount of the angiogenesis that happens and inhibition that happens, that also been studied. But when it comes to the clinic, it's the effects are different. That's why it is exciting. And two different pathways always will be better than one pathway, definitely. And we will see whether it is clinically be very effective or not.
Yes, sir.
Okay, sir.
Chandramohan.
Dr.
Thank you.
Chandramohan now.
Thank you, Lalit sir, Ajit sir, and my colleagues for giving me the opportunity. And this talk is sponsored by Roshi. So we all know that neovascular AMD is the most important cause of loss of vision in elderly age group. So at present, more than 20 million people are affected globally with neovascular AMD, and it's going to increase more than 57% by 2400. Indian studies have shown that 0.11 to 1.2 is the incidence of neovascular AMD or wet AMD. And we have seen all these molecules coming from Macugen to brolucizumab, which are present available to us in our armamentarium, all targeting the anti-VEGF as sirs are discussing. So, and we also have seen what Ajit Babu sir told, the clinical experimental scenario, trial scenario doesn't reflect in the real world scenario. The causes are multiple. Multiple injections needed very frequently, every 4 weekly, or for every patient visit there should be some attender who has to bring the patient, take, and as Lalit sir had told, a lot of investigations to be done. So a lot of work in this attitude. So anti-VEGF does not completely address the multifactorial nature of disease. And as we are all discussing, the inflammatory component, which is one of the important thing, we are concentrating on the angiogenic component. So these are the molecules that have come. This is a novel therapy now. Mechanism of action targeting additional pathways. The neutralization of both angiotensin 2 and VEGF-A. So we all know that inflammation, vascular leakage, neovascularization, fibrosis is the pathogenesis for neovascular AMD. And this is the endothelium which has got Tie2 receptors to which the angiotensin 1 binds, and tyrosine kinase pathway is activated. That is responsible for the stability of the vascular vessels. So angiotensin 2 competes with angiotensin 1. So if there is more angiotensin 2, then it competes with angiotensin and blocks this kinase. Sir, as I told Sir Lalit sir, this is the slide which shows there is elevated levels of angiotensin 2 in the vitreous cavity in compared to controls. It is increased in nAMD, and you can see that it is highest in RVO, sir, then in DR, and then proliferative diabetic retinopathy. So this is a study which shows that the angiotensin 2 levels are increased in all these pathologies which we are interested, including neovascular AMD, when compared to controls. So there is a definite increase in angiotensin 2 in these pathologies. So this block of this, when angiotensin 2 binds this pathway, this is the one that is responsible for breakdown of endothelial, tight endothelial junctions, loss of pericytes, and which then promotes this new vessel formation. So these two have synergistic effects. If there is more angiotensin 2, then it also facilitates VEGF to leakage. So angiotensin adds to the leakage effect of VEGF. So they act synergistically. So both they increase the inflammation, vascular leakage, and fibrosis. So as Rajesh has already told, it's an immunoglobulin FC fragment, has got 2 FAB fragments. The 2 FAB fragments, one fragment is replaced by anti-angiogen 2, and another is replaced by anti-VEGF. So it blocks both because each fragment is. So now we will come into the clinical scenario. Till now we are studying about the molecules, and Rajesh has clearly told that there is elevated levels of angiotensin and we are blocking this angiotensin 2. But how does it work in AMD? There are large phase 3 trials, TINAYA and Lucerin, parallel trials that have been conducted to study the efficacy of this in real world scenario. This is 3-year, 2 results in AMD. These 2 studies are concurrent studies. They have taken extrafoveal, juxtafoveal, subfoveal, neovascular AMD, secondary to only age-related macular degeneration. So this study has not taken any neovascularization other than nAMD. So nAMD is the one that has been taken into consideration. So I'll just give small outline of the study. This is the molecule Vabysmo is compared with that of efilbercept, which is the standard of molecule that has been used now. So in the efilbercept arm, let me make it clear, it's very simple. First 3 monthly loading doses, 3 injections have been given. After that, every 2 monthly is the injection. For 1 year, which is the study endpoint, a primary endpoint is studied at the end of 1 year, and the study was continued to 2.6 years, 2 years, 6 months. So efilbercept, very clear, 3 1 monthly dose, 3 doses. After that, every 2 monthly 1 injection. Whereas in the case of faricimab arm, the loading dose is also same, like 1 monthly for first 4 months. So there is 1 injection extra that is given. But the next disease activity was assessed after 2 months. If there is disease activity after 2 months following the loading dose, then the dose of 2 months is continued, every 2 monthly injection. But if there, at the end of 2 months following the loading dose, there is no activity, then the next assessment is 3 months. If there is activity of 3 months, then the dosage is continued as 3 months. If there is activity of 4 months, then the dose is continued as 4 months. So we have 3 arms, which are 2 months, 3 months, and 4 months of loading doses in this. So the disease activity is taken as both visual acuity as well as recurrence of OCT or appearance of new hemorrhage. So if you see that both vision and anatomical criteria is required, 96% have been in the quarterly 12 or 3 monthly. So majority of them had 3 monthly doses. So it's done in different centers in the whole world and equal number of patients. I'll skip these things. I'll concentrate on 2 slides. One is this visual acuity thing. You can see that it has done very well when compared with efilbercept, 6.2 letter gain at the end of 1 year, 5.8 when compared to efilbercept, and also 4.3 letters at the end of 2 years, 6 months. I want to just highlight 10 injections of faricimab, whereas 8 injections of in the first median number of injections in the first year. The next year you can see that 3 injections of faricimab, 6 injections of efilbercept. I'll just see it. And OCT results are also same, drying effect are also same, with less number of injections. So initial 3 loading doses also, the visual acuity gain is higher when compared to efilbercept, and also the drying effect is also very good when compared to efilbercept in the initial 3. So 80% have achieved 3 monthly dosing, 80% have achieved 3 monthly dosing at the end of 2.6 years. Not much of side effects. And PCV also the results have been same. So I'll just skip these slides and say that Vabysmo has got dual inhibition action, faster decrease in thickness, faster improvement in visual acuity, and extended durability. Thank you. Thank you.
What you say is that it's working. Right?
Yeah.
What you say is that it is non-inferior to efilbercept.
Yes, sir.
In terms of BCVA, in terms of drying.
Drying. Yes, sir.
The only advantage we are looking for is the duration.
Duration, sir. Yes.
And duration we are extended by 16.
Yes, sir. 16.
Yeah, so the advantages of extended duration, but we have to remember that this is not a comparative study where the aflibercept was not extended.
Yes, madam. Yes,
So, but aflibercept is kept at 2 monthly because that is the best dosing.
Yes.
So to compare the visual results, you have to use a comparator which is excellent so that you can compare the visual results. But if aflibercept is also allowed to be extended, then we would have a head-to-head trial.
Yes, but exact comparison, if you want to do, then we have to extend even efilbercept also. But the previous studies have shown that every 2 months it repeated, so they kept the efilbercept arm as a standard
On-label
2 monthly dosing after the first 3 loading doses. But faricimab, they tried 3 different doses. 80% of the patient have come into 4 monthly dose, madam. When visual acuity and OCT, 3 monthly. Thing.
See now, even with the aflibercept, we do see the Altair shows us about 60% can go to Q16, and here 80% are going to Q16. So that is the difference in the data. Q12, both are going to, more than 60% are going to Q12.
Yes.
I think there is a small percentage which is higher going into Q16, which is about 10 to 20% of the patients.
You see, that itself may, you see 20% of what Malika was saying, 20% patients in case we can extend by, Q16. It does make a dent for a lot of these patients, because a lot of these patients don't want to come.
During the loading dose period also, sir, immediate within one or
Is there any wow effect in this, that patient says next day, and I wanted to ask Rajesh also, that how long does it take for the effect to come?
so that's what the initial 4 loading doses were compared, sir. In the loading doses, drying was little earlier with one injection in Vabysmo group when compared to FL. But similarly, the vision improvement
Earlier means patient you have injected.
in the first 4 months of loading doses. 3 months for FL versus 4 months for FL.
What I am asking is, when does the effect come?
Yeah,
Patient
1
comes,
week, 2
1
weeks,
week,
what
2
is
weeks.
the peak?
4 weeks, there is a difference between with one injection, first loading dose itself. They claim that during when compared these two things, the drying effect comes early within 4 weeks, and visual gain also comes within 4 weeks with the first injection.
Okay.
This slides.
Okay, we have heard about Tanya and Lucerne, Tenaya and Lucerne, sorry, and now let's hear about the Yosemite and Rhine, because of that I think this is the DME problem.
Yes.
So,
Thank you.
speaker will.
DME, but what we need to understand is, in Ozudex, when it is introduced, it was introduced with a 6 months promise. That
It
will
does
work
not
for-
last 6 months, it's only 3-4 months.
See, what happens is the basic studies always they aim for a higher duration of this. And that is what is required now, because we have the injections in our armamenta, but we want to reduce the frequency. And the patients also tell us, sir, it is a little bit very frequent, I want it to postpone. Even if it is twice a year, I would take it, no problem, even if it is for a very long duration, means for few years and all. But what the basic studies promise us is much longer, and when it comes to the clinic, somehow the effect is wearing off. Like Ozudex, it's weared off from 6 months promise, 6 months it is only works for 3 months. So even
let
in
me ask James.
Faricimab also, let us.
James, for you, efficacy is more important, duration is more important.
Both
You
are
see, both you can't say, one by one. Why I want to know is because
should
if
be
the claim is that it is non-inferior, and it may be Q16 or Q12, with this similar efficacy as aflibercept. So what is more important for you, efficacy or duration?
Efficacy, duration.
Don't say both. I know both are important. But
Yeah, both are important. The other thing is economics also. We don't know, it's not been launched as yet. What would be the cost to the patient? That also matters in our scenario. Most of the studies, when we anything is launched, like what
economics come at the end. You see, if my eye it is there, if I start seeing better, I am ready to pay also.
correct.
If I don't see, I will not pay.
The first would be the efficacy.
Yeah.
No, efficacy both are equal, he said. So
So
now
we need
what
to
is your
we need to wait for the actual studies. These are like
Exactly.
industry based
now
studies.
you come to the point. Because what we are talking is
Industry
you see,
based studies.
RCTs.
These are RCTs and there are promised duration by the industry. Okay.
Exactly.
In
So
the
we need to
clinic,
wait.
that is stage 4. Like
Yeah,
the
we
level
need
of studies.
Yes.
Once the RCTs are over, then in the clinic how effective it is.
Yes. So it's
That we need to
it's different for
experience.
each individual. At the same time, we need to wait for our actual studies to come out
So let us give
No,
a
no,
hypothetical.
from the academia. Like
So let us give a hypothetical things. We take it for granted that in real world scenario also this may be possible, that with this similar efficacy the duration is more. Then I think
Then we
we have
need to
passed that.
duration.
Then we have passed that acid test. Then I think this can become number one,
correct.
provided similar efficacy or better efficacy. Well, and drying also. You see, two, 3 Ds are important.
Correct.
Duration, drying, double mechanism. All these things are there.
Yes.
Then duration becomes important.
Duration becomes
So efficacy has to be similar.
correct.
It's a 3D molecule, let us.
So let's hear Samira. Samira, are you ready?
So
Any
that's
your
what
take,
I'm
your
saying
take,
is,
your take. Bhavi.
So if efficacy is the same, obviously duration
Mic,
is.
mic.
If, es-
Use the microphone.
if efficacy is the same, duration becomes extremely important.
Yeah,
because
that's what I said.
Yes,
If
true.
duration is, if
Agreed
the
with your
efficacy is
point.
same, duration matters a lot.
Correct. Because it's not just about the patient ready to come. Something called as patient fatigue also sets in. Though even he is affordable, he can still pay. But that pain of coming every time to the hospital,
I
to
agree.
take an
Patient
injection,
actually tang aa jata na. Patient
and that is
starts,
where a lot of our diabetic patients lose out. And it's not that they may have a chauffeur-driven car, but it's just that fatigue of the patient to come to the institute or to the hospital makes a difference. Yeah.
Also physician fatigue. We also get tired.
Physician fatigue gets with, yeah.
Is
So
at
that's
all
where the
levels.
holiday.
Because fatigue is at level of individual, patient, family, everybody gets fed up, na?
Yes.
भाई बार-बार डॉक्टर के पास जाना, बार-बार जाना, बार-बार जाना. So here is the role of duration.
Correct.
Yeah.
So let's hear Samira, what do you have to say for this Yosemite and Rhine studies?
Good morning, all.
Mike.
Good morning, all. Thanks for this opportunity. There is nil financial disclosure. I shall be talking on phase 3 clinical trial of faricimab in diabetic macular edema, which was published in Lancet in February 2022. What happened? It's coming. The study purpose was to evaluate the efficacy, safety, pharmacokinetics, and durability of intravitreal faricimab 6 mg for the treatment of diabetic macular edema when dosed either every 8 weeks or according to a PTR regimen in adjustable intervals up to 16 weeks compared with intravitreal aflibercept 2 mg dosed every 8 weeks. And these two studies were identically designed, double-masked, multi-center, randomized, parallel group registrational phase 3 studies. These two studies were conducted across US, Europe, Asia, and North America. The study enrollment started in September 2018 and it ended in August 2021. Adults aged 18 years or older with center involving macular edema secondary to type 1 and type 2 diabetes mellitus were included in the study. Can you use this? Oh, this is happening.
Audiovisual issue. So, any comment from any?
From the audience. We'll take one comment. Yeah.
Nobody. Because
They
our
are just observing very keenly.
yes,
Like
yes,
a
carry on,
cricket match
carry on.
between India and Pakistan. Right? From 2 o'clock it's going to start.
One eye per patient with best corrected visual acuity between 2040 to 2320 was included in the study. Central subfield thickness 325 micron or more was one of the inclusion criteria. Any VGF treatment naive or previously treated eye, both were actually included in the study. The previously treated study eyes numbers were limited to 25% of total enrollment. And all these patients were randomly assigned 1:1:1 into 3 treatment arms. The first treatment arm was intravitreal faricimab 6 mg every 8 weeks In this arm, all patients received 6 injections of 6 milligram faricimab initially as loading dose, and then they received 6 milligram faricimab every 8 weeks. The second treatment arm received first 4 monthly injections of faricimab 6 milligram, and then faricimab injection was decided based on personalized treatment interval regimen. In this, the extent of injection interval was up to 16 weeks, depending on the case scenario. The third arm of the trial received monthly intravitreal injections of 2 milligram of aflibercept for 5 injections, and then aflibercept was injected at 8 weeks interval to maintain the masking. All these patients were being called to the clinic every month, and the investigations also were done every month. And when there is no injection to be scheduled, then they got SAM injection. Patients in the faricimab PTI arms followed a treat and extend based personalized dosing regimen using a protocol-driven algorithm based on changes in CST and BCVA. During the initial phase, patients received monthly faricimab injection until they achieved central subfield thickness less than 320 micron at or after 12 weeks. And once this was achieved, then the next injection was decided as per the protocol, that is PTI, based on its central subfield thickness and best corrected visual acuity.
Can we have a permanent solution for this? वो बार-बार उसको आप press कर
Yes, yes. Should I take
no
the
permanent
pen
solution.
drive and transfer it?
What Monica was saying, but same happens with anti-VEGF also. There's no permanent. People keep coming. Audiovisual people are coming every 4 minutes. So just to make this discussion more exciting, I think all of us are waiting for the launch of. Although we have this data available now, all of us are very eagerly waiting that when will it be available. Anybody from Roche is here? Roche का कोई है?
रोश का है ना वो रेणुका
People are busy. Roche, you are there from Roche.
yeah
So when it is likely to come, madam?
Now, please come on to the dais and take this microphone and speak.
The question is that all of us are eagerly waiting. So when it is likely that first injection of Vabysmo will be injected in India?
Sir, mostly we are
Mike.
launching in VRSA, sir.
You tell the date, na? We are asking the date.
Date is not yet released, sir.
Month?
First week of December, yeah.
First week of
December.
December it will be launched. And any idea about the costing?
Unofficially, it is 88,000. I'm taking her quote as this thing, and it will be 1+1 offer will be there. So it is like 44 to 45,000 per injection.
Just a minute.
Provided the
minute,
company,
minute.
whatever it promised, like 16 weeks if it happens, really I will be very happy. And I'm hopeful because
So
it is
Ajit
a
Babu,
dual
are,
action.
Ajit Babu, are you going to shift all your patients? Are
If
you going
it
to
is-
shift, yes or no?
If it is 16 weeks, majority will be shifted. Not me, but they will ask.
Yeah. Are you ready, Samira?
Renuka, if anybody from the science side is there in Roche, can you tell us if it is more viscous and whether the injection needle gauge has to be
Yeah, the
changed?
viscosity of the injection.
Because
and
we understand that it is more viscous, it takes more time to prepare.
injection, gauze of the injection.
So can somebody tell us what is the wider
Any
gauge needle
medical
required?
person, you can call them and then.
Somebody is there from Roche?
Medical person is there.
I have heard is that it's slightly difficult to inject. So is 30 gauge needle the more, is the appropriate needle, or you are going to have 29 or maybe? इंजेक्ट किससे करेंगे? इंजेक्ट किससे करेंगे? वो तो फिल्टर तो ठीक है.
Usually 30 Ks only.
You see, I for
So
one
it is
know, I for
30.
one know that this you know, they haven't got DCGI ka final clearance, and you know, for last 2-3 months it is stuck. And initially Roche had promised that they will do it in October, November, December now. So I use your might, whatever, to get this clearance as fast as possible, because otherwise this excitement, you know,
Yes,
is in everybody's mind. Because RCTs are something else, but real world scenario is what you are waiting for. And believe me, the day it comes, people are going to inject and see, and then we will have huge number of presentations. It works nicely, it does not work, whatever. So that is what is important.
It's mainly the post hoc analysis.
Yes, Samira.
Especially after the RCT in the clinic, how it is working is more important than anything else.
Yes, madam.
Yes. The primary endpoint was to evaluate the efficacy of intravitreal injection of faricimab 6 mg on best-corrected visual outcomes as measured by change from baseline in BCVA at 1 year, determined as the average change in BCVA from baseline at week 48, 52, 56. It's not moving. So there are several secondary endpoints. I'll not, discuss this in the results section. It's not moving. This one?
Yes, ma'am.
Okay. So there are total 1,532 patients were screened, and out of which 940 patients were enrolled for the study. And there were some dropouts during COVID time, and finally 282, 283, and 285 patients remained at the end of the study who were taking treatment. But for analysis, they have considered intention to treat, and they have taken 315, 313, and 312 patients in the first trial. And in Rhine, total 1,715 patients were screened for the study, out of which 951 were enrolled. And for analysis, 317, 319, and 315 patients were considered as per the intention to treat analysis in all these three arms respectively. Baseline characters of three groups in each study are comparable. In this study, primary endpoint at 1 year was achieved with an average of 10 to 11 letters gained, which was maintained to year 2 in all treatment arms. These mean vision gain were comparable for all treatment arms. This was achieved with faricimab PTI arm having fewer median injections versus aflibercept, that is 11 versus 14 respectively. In addition to vision gain, faricimab demonstrated greater mean reduction in CST versus aflibercept at 1 year, which was maintained through year 2, and this was achieved with faricimab PTI arm having fewer median injections versus aflibercept, 11 versus 14. In post-hoc analysis, first absence of DME was achieved faster and in more patients treated with faricimab versus aflibercept. Absence of DME, which was 75% achieved at week 20 in faricimab groups with average 4.8 or 4.2 injections. In aflibercept group, this was achieved at week 36 after an average of 6.7 injection. Again, in a post-hoc analysis, first absence of intraretinal fluid was achieved faster and in more patients treated with faricimab versus aflibercept. This time point at which the cumulative incidence of absence of DME reached 50% was week 48 in faricimab after an average of 8.4 or 7.5 injections respectively. In aflibercept arm, the 50th percentile was reached at week 84 after an average of 11.7 injections. There was greater reduction in macular leakage area with faricimab. More faricimab patients had resolution of macular leakage. And in faricimab PTI arm, at 1 year, more than 70% of patients achieved extended interval of 12 or 16-week interval dosing with faricimab, which increased to 80% at second year, by second year. The proportion of patients on 16-week interval dosing increased from 52% to 52% at week 52 to 60% at week 96. Faricimab was well tolerated with an acceptable safety profile. Rate of intraocular inflammation was low and comparable between treatment arms in DME. No cases of retinal vasculitis or intraocular inflammation due to retinal occlusive vasculitis was noted. In summary, faricimab PTI arm demonstrated durable efficiency and safety for DME over 2 years. Comparable vision gain with fewer injections, improved and rapid decrease in CST and yeah. So there are a couple of other reports coming off related to faricimab, not related to this study. One such report is resolution of hyperreflective foci in DME. Faricimab reduced hyperreflective foci volumes significantly as compared to aflibercept. And faricimab reduced hyperreflective foci in outer retina as well as inner retina as compared to aflibercept. The second report coming off is effect of faricimab on epiretinal membrane formation. Through week 100, faricimab led to 52% reduction in the risk of epiretinal membrane formation. Thank you.
Thank you, Samira, for highlighting the usage of faricimab in UZIMITE and RHINE trials. I think by and large, similar figures as Tanaya and Lucerne about the efficacy, about the durability. So I still, will conclude by saying that drug is promising. There's a lot of excitement in the air. All of us are waiting, and I just wanted to know if anybody knows what percentage of patients in West or USA have shifted from, say, aflibercept or Accentrix or ranibizumab to faricimab, because they will definitely have more experience in this. And I will request Roche people, whenever we have session like these, we should have one person online maybe in the beginning to tell his or her experience. You see, as of today, we are talking theory. All of us are waiting, as I said, for December launch here. And if we have some data, anybody from Roche?
This trial has included both treatment-naive patients as well as already treated patients. And in already treated group, they had already received other anti-VEGF injection, but number of patients, already treated patients, they have kept to 25% of the total enrollment.
So let us just summarize now, because it's the end of the session. As we already discussed, that in these trials, we have only trial data is that we can extend to Q12 in over 80% of the patients, and to Q16 in about 50% to 60% of the patients, which if you compare with trials for aflibercept comes to 60% of the patients can be extended to Q12 and 40% to Q16. So there is about a 20% difference in the two drugs, that is. Now these are RCTs. In reality, when we actually work, the results are very different. We have many patients with aflibercept who are going to 6 months, 4 months, easily, even 10 months. So even with this new drug, now we have to see whether those patients who are not responding well enough to aflibercept, who require Q12 or Q8 injections, whether they can be extended. So there is going to be a small proportion of patients, possibly 10% or more, which may require this drug, which are not responding well enough to aflibercept.
So let us conclude this session by saying that we are waiting for this 20% advantage. 20% advantage, as Malika said, is, I think, for me, good enough to force me to shift a lot of my patients from existing molecules to faricimab. So with this, I thank all the speakers as well as moderators here, and thank the Roche company for helping us conduct this wonderful session. Any last comments?
Probably next year we will come with more experience regarding the duration of effectiveness of the drug.
So
Thank you we will thank all the people and all the audience, mainly in large number they were. You want to say something?
Yeah, they have measured the level of VEGF and angiopoietin level in aqueous as well as in vitreous in few samples, few patients, and they have shown that this is working beyond 4 weeks, and 8 weeks also it is very significant.
No, I am very optimistic. Means even if it works for 20 weeks, I will be very happy. But skepticism always prevails.
It's an exciting drug, looks
yeah.
like. I think, but we should not go by the face value only. We need to wait and
we should always wait for the clinical,
I agree.
Exactly.
The thing is that real world has to ultimately
Exactly.
be the king.
I think that's more important than
that
anything.
will be the king that, like Ajit Babu said,
I am
next
with
year,
the audience.
Yes.
Next year
If they use, it should last for longer.
Correct.
Yes. Okay. Next year, yours. We'll come next year with a good experience. Okay.